Usually when we talk about like a medical diagnosis, there's this expectation of precision.
Right, yeah, but it's clear cut.
Yeah, exactly. It's almost like engineering. Say you're riding a bike, you take a bad fall, you break your arm, you go to the hospital, they put you in a machine, and a few minutes later, the X-ray shows that jagged white line on a glowing screen. And the doctor just points to it and says, there it is. That's the problem.
Right, it's binary. It's
Uh-huh.
clean. You can point to the exact millimeter where the bone failed.
Exactly. It's either broken or not broken. And honestly, it's comforting.
It is.
We like things to be visible. We like our problems to be um, neatly categorized so we know exactly how to cast them and heal them.
We really crave that certainty. I mean, if we can see the mechanism of the injury, we feel like we have control over the recovery.
Yeah, but then you step into the world of human emotion, specifically the realms of profound loss, neurodevelopment, and psychological trauma, and suddenly that X-ray machine is just broken. We are looking at a diagnostic landscape that is entirely murky. And today, for you, the learner listening to this right now, we are wading directly into those murky water.
We really are.
Welcome to this deep dive. Today, we are looking at the actual, literal hardware of human suffering.
The biology of it, yeah.
Right. We're going to find out why a broken heart looks exactly like a broken bone on an MRI, why severe trauma literally erases our brain's ability to speak, and how therapists use children's toys to hack into our oldest, most primal defense systems.
It's heavy terrain, undoubtedly. But understanding the mechanisms behind our pain, looking under the hood at how our brains biologically process these devastating events, that's actually the very first step in demystifying the recovery process.
Which is so important.
Exactly. And my role today is to bring the clinical data to help connect the dots between the raw, chaotic emotion of a profound loss and the actual physical wiring of our nervous system.
And I'll be right here asking the questions we all have, trying to make sense of this massive stack of medical journals, counseling handbooks, and psychiatric texts we've compiled.
Quite a stack.
It is. And I want to start with something I always assumed was pretty straightforward. But the sources we're looking at today are incredibly precise about the terminology.
Yes, they are.
Because I always assume that if someone loses a person they love, they're grieving. Period. Like it's all one big bucket of sadness. But the clinical literature splits hairs over these words.
They do, and for a very good reason. I mean, in a clinical setting, using the wrong terminology it can completely misguide the treatment plan.
Wow, really?
Yeah. It is vital to differentiate between what happens to us, how we feel about it, and how we process it. So let's start with the most basic term, which is loss.
Okay, loss.
Loss is simply the objective state of being deprived of something or someone you once had.
So it's just the fact of it.
Exactly. It's the factual event. It's a data point on a timeline. The loss occurred at this time on this date. Grief, on the other hand, is the internal reaction to that loss. It's the pain, the suffering, the emotional, physical, and cognitive whirlwind that happens inside the body and mind after the factual event.
Okay, so loss is the event. It's the noun. And grief is the internal reaction. It's what you feel in your chest.
Right.
So where do mourning and bereavement fit into this? Because I use those interchangeably with grief all the time.
Most people do, yeah. But mourning is the active external process.
External.
Yes.
Yeah.
It's the period of time during which signs of grief are shown to the world. It is the psychological and social process of adapting to the loss.
Oh, like rituals.
Exactly. A funeral is a mourning ritual. Wearing black is a mourning practice. And finally, you have bereavement, which is a very specific category.
Okay, what's that one?
It's the reaction to the loss of a close relationship, specifically through death. It encompasses the entire experience. So the factual loss, the internal grief, the external mourning, and the long-term adaptation.
Okay, wait. So if loss is just the factual event, why do therapists care so much about differentiating the internal grief from the external mourning? I mean, does using the wrong word actually impact how a counselor talks to a patient?
Absolutely. Imagine a patient who is experiencing profound internal grief, but their cultural background suppresses external mourning.
Oh, I see.
Right. If a therapist expects mourning to look a certain way, say crying in the therapy room, and the patient doesn't do that, the therapist might mistakenly diagnose them as being in denial or detached.
Because they aren't performing it the way the therapist expects.
Precisely. And conversely, someone might be participating heavily in the external mourning rituals of their community without actually processing their internal grief. So by separating the terms, a counselor can pinpoint exactly where a person might be stuck.
That distinction makes a lot of sense because when we talk about mourning and adapting and being stuck, almost everyone's mind immediately goes to the exact same place.
Kubler-Ross.
Yep. Elizabeth Kubler-Ross and the famous 5 stages of grief. Denial, anger, bargaining, depression, and acceptance.
Right.
It's basically gospel in top culture. I mean, it's in movies, books, everyday conversation.
Yes, the 5 stages are deeply, perhaps permanently, embedded in our cultural consciousness. But our sources make it very clear that as a society, we need to completely dismantle the strict interpretation of those stages.
Wait, really?
Yes, we have fundamentally misunderstood her work.
How so? Like, what did we get wrong?
Well, Kubler-Ross originally designed those stages in the 1960s to describe the process of a patient coming to terms with their own terminal illness.
Oh, wow. I didn't know that.
Yeah, she was observing dying patients, not the survivors left behind after a death. Over time, society sort of co-opted those stages and applied them to anyone experiencing grief.
Which implies that grief is this, neat linear checklist.
Exactly.
You do a little denial, you get mad for a while, you bargain with the universe, you get sad, and then boom, you hit acceptance and you're cured, you get a certificate of completion.
Precisely. And that is incredibly damaging.
Because it's not a straight line.
No, grief is not a staircase where you reach the top and you're suddenly healed. It's an active, highly cyclical process of adaptation. It progresses in fits and starts. It ebbs and flows.
It's messy.
Very messy. A person might feel a genuine sense of acceptance one day, and then a sensory trigger. A smell of a certain cologne, a song on the radio, a particular date on the calendar sends them right back into profound anger or deep depression the next. It's a series of tailspins and recoveries, not a straight line.
Okay, let's unpack this, which brings us to what the research actually says about how people mourn. Our sources outline 4 normal patterns of grief. And I want to highlight the word normal here for you listening.
Yes, normal is key.
These are resilience, chronic grief, depressed improved, and chronic depression. And I was reading through these, and the depressed improved pattern completely blew my mind.
It's a highly counterintuitive finding for many people, and it often carries a lot of misplaced guilt.
Let me explain it for the listener, because it's wild. According to the data, about 1 in 10 individuals experience this depressed improved pattern. And this happens when the death actually releases the griever from a chronic, overwhelming stressor.
Can you give an example of what that looks like in practice?
Yeah. Imagine a spouse who has been the sole caregiver for a partner with, say, severe early onset Alzheimer's for a decade.
Okay.
10 years of watching the person they love disappear, 10 years of physical exhaustion, financial ruin, and total isolation. In that scenario, the profound depressed phase actually happens before the loss.
Right. They've been grieving the person while they were still alive.
Exactly. Then the physical death occurs, and suddenly the surviving spouse's daily functioning actually improves. They can sleep, they can reconnect with friends, their depression lifts.
And it is absolutely crucial to understand that clinically, this is classified as a normal, healthy pattern of adaptation.
Even though they feel better after someone dies.
Yes. The griever is able to focus on positive memories, find meaning, and experience the physiological benefits of living without that crushing chronic stressor.
But society must judge them so harshly for that. Like, oh, look how happy they are. They must not have cared.
They do, and worse. The grievers often judge themselves. They feel immense guilt for feeling a sense of relief. But experiencing relief doesn't mean they didn't love the person or that they're callous. It simply means a heavy, unrelenting biological and psychological burden has been lifted.
The body is finally allowed to rest.
Exactly.
Okay, I want to pivot and ask you about another one of these normal patterns, because this is where I really found myself questioning the data. The sources say that 46% of people experience the resilience pattern.
Yes.
Meaning almost half of all bereaved people show a relatively low level of chronic distress or almost no outward signs of grief whatsoever. I have to push back here.
Go ahead.
Wait, almost half. If I go to a funeral and the widower isn't crying, he's chatting with people, he goes back to work on Monday. You're telling me his brain isn't broken? How do we know he isn't just deeply in denial, repressing all this emotion until he eventually explodes?
What's fascinating here is that the clinical research totally flips our cultural assumptions upside down.
Okay.
For a very long time, even trained psychologists thought exactly what you're thinking. They thought this resilience was abnormal, that these people were repressing their emotions, and that they needed therapeutic intervention to just let it all out.
Right. There was this belief in the, what is it, the grief work hypothesis.
Yes, the idea that you have to experience profound agony to process a loss.
You have to pay the toll.
Exactly. But careful longitudinal research has revealed that resilience is biologically and psychologically normal for a massive portion of the population.
Hell.
Yes. About half of us have an innate baseline capacity to integrate a major loss without experiencing a severe disruption to our daily functioning.
So it really isn't denial. They aren't faking it.
No, they are not. Our cultural expectations, particularly in Western societies, often demand a public performance of devastation. We expect people to fall apart.
We really do.
And this expectation conflicts with natural psychological resilience. Grief does not mandate a breakdown in functioning. If a person is eating well, sleeping normally, maintaining their relationships, and even finding moments of genuine joy shortly after a massive loss, they aren't necessarily broken.
And they aren't suppressing a time bomb of emotion.
No, they might just be part of that 46% who are highly resilient.
That is incredibly liberating for anyone listening who might have judged themselves for not falling apart after a loss, who thought, you know, what is wrong with me? Why aren't I crying every day?
It should be liberating. We have pathologized strength for too long.
Yeah. But while resilience is incredibly common, there is a specific minority of people whose brains process the loss entirely differently, right?
Yes, and this is a critical pivot in our understanding of the brain. While the vast majority of people eventually adapt, whether through resilience or by slowly working through chronic grief over time, there's a subgroup, roughly 7% of those who experience grief, whose profound sorrow simply does not abate.
7%.
Yes. Their brains respond to the loss in a way that leads to a state that is decidedly not normal, known clinically as complicated grief.
And complicated grief, or CGU as the medical journals sometimes abbreviate it, is a distinct psychiatric syndrome. It's not just grieving a lot.
No, it's much more severe.
It features unrelenting sorrow, disabling yearning, and a very specific set of symptoms that persist for over 12 months in adults.
We're talking about marked difficulty accepting the death, intense emotional numbness, pervasive bitterness, a feeling that life holds no meaning anymore, and an excessive, almost phobic avoidance of anything that reminds them of the loss.
The functional impairment is severe. People with complicated grief often cannot work, cannot maintain relationships, and they suffer from high rates of suicidal ideation.
It's devastating. It is. But to truly understand why complicated grief is so incredibly intractable, why these people just can't, snap out of it, we have to look at what is physically happening inside the architecture of the brain.
Right.
Our sources include a fascinating functional MRI study published in the journal Neuroimage.
This study is wild. Let me set the scene for the listener. The researchers took two groups of bereaved women. All of them had lost a mother or a sister to breast cancer within the past 5 years.
Okay.
One group had been diagnosed with non-complicated grief. They were adapting normally. The other group had been diagnosed with complicated grief. So they put these women inside a brain scanner, a functional MRI machine, and showed them pictures of their deceased loved one alongside specific words related to their grief.
And what they found initially, when looking at the scans, was a profound similarity between the two groups.
Okay, what was similar?
Both the normal grievers and the complicated grievers showed intense activation in the brain's pain network.
Right, the sources list some intense neurojargon here. The dorsal anterior cingulate cortex, the insula, and the periaqueductal gray. Can you translate that for us? What do those areas actually do?
Those brain regions are the exact same neuronal pathways that light up when you experience acute physical pain.
Wait, like getting hurt physically?
Exactly. If you accidentally touch a remarkably hot stove, or if you break your arm, like in our earlier example, your dorsal anterior cingulate cortex, or DACC, acts as the alarm bell.
Yes.
Screams, "This hurts, pay attention, something is wrong."
Which proves something incredibly profound right there. Social pain, like the pain of rejection or the agonizing loss of a loved one, activates the exact same neuronal patterns in the brain as noxious physical pain.
Yes.
Evolutionarily speaking, a broken heart looks remarkably like a broken bone on a brain scan.
It really does. Evolution wired us as social creatures. To a primitive human, being separated from the tribe meant certain death by starvation or predation.
Right, you need the group to survive.
Exactly. So the brain evolved to make social separation literally physically hurt, to force us to stay together. The suffering of grief is biologically real. It's not just in your head, it is in your nervous system.
But the critical discovery of this neuroimage study wasn't the similarity between the two groups, it was the difference.
Exactly. When viewing pictures of their deceased loved ones, Only the women diagnosed with complicated grief showed significant activation in a completely different region of the brain, the nucleus accumbens.
Here's where it gets really interesting, because the nucleus accumbens is the brain's reward center, right?
Yes, it is.
It's the area most commonly associated with anticipation of a reward, like eating a delicious meal or winning money or taking an addictive drug. So if I'm understanding this mechanism correctly, we can basically compare complicated grief to an addiction.
Yes, that's a very accurate way to frame it.
If the nucleus accumbens is firing when they see a picture of the deceased, the griever is essentially experiencing a literal neurochemical craving for their lost loved one.
That is exactly the analogy the neuroscientists draw, and it's a paradigm-shifting way to look at grief.
So having pleasurable reveries about the past, daydreaming about the person, smelling their old clothes in the closet, it acts like a drug hit for someone with complicated grief. You give them a spike of dopamine.
Exactly.
But it's a hit that prevents them from adapting to the reality of the present, because the drug they are craving is a person who no longer exists.
You've hit the nail on the head. To understand why this happens, we have to look again at how evolution tied attachment to reward.
Okay, how so?
The human brain has deeply grooved dopaminergic and oxytocinergic pathways. Dopamine drives motivation and reward. Oxytocin drives bonding and trust. These chemical pathways are specifically designed to enforce social attachment, like the unbreakable bond between a mother and a child, or between siblings.
Right.
Evolution desperately wants us to stay close to our kin, so it makes being near them feel highly rewarding. It literally feels good to be with the people we love.
Because if it didn't feel good, we wouldn't bother raising vulnerable human infants, right? We need the chemical hit to keep us bonded.
Precisely. In normal grief, over time, the brain's predictive models learn that the person is gone. The reward circuitry slowly stops firing when presented with cues of the deceased because the brain realizes the reward, the person, is no longer available.
It updates the software?
Yes. This is often called the detachment model of grief. The pain of the loss eventually leads to neurological acceptance. But in complicated grief, the brain gets hijacked.
Hijack how?
The reunion model seems to apply. The cues of the deceased continue to trigger that reward activity in the nucleus accumbens. The brain is motivated to seek a reunion that is physically impossible.
Oh, wow.
It's sending signals saying, go find them. The reward is waiting. This craving makes adapting to the reality of the loss incredibly difficult. It's identical to an individual battling a severe substance addiction, struggling to adapt to life without the substance. The drug is the memory.
Wow. Think about how that shifts our entire cultural perspective on someone who has been grieving heavily for, say, 3 years.
It changes everything.
Usually people get frustrated, they say they need to move on, or they're choosing a wallow in the past. But if someone is ruminating and yearning constantly, they're fighting a literal neurochemical craving. They are battling their own nucleus accumbens.
It's a are.
That means they don't need a pep talk, they need intervention for a hijacked reward system.
Exactly. It removes the moral judgment from prolonged grief. And this intense physical reality, the way an event fundamentally alters brain activity, is the perfect bridge to explore our next topic.
Which is trauma.
Yes, because if complicated grief is the brain's reward center getting hijacked by the past, what happens when the brain is hijacked by sudden, overwhelming fear? How does the hardware change then?
Right. And that brings us to the architecture of trauma. Let's define what we mean by trauma in this clinical context, because a lot of people use the word loosely today. Someone might say, I got a bad haircut, it was so traumatic.
Right, the colloquial use is really expanded.
But the medical literature gives us a very specific, stringent psychological definition.
It does. The defining moment of psychological trauma occurs when an experience violently violates a deeply held belief or core worldview. It is an event that fundamentally shatters a person's template for how the world operates.
You mean beliefs like the world is generally a safe place, or good people don't die young, or for a child, the adults in my life will protect me?
Yes. We all walk around with these invisible psychological schemas that allow us to function without constant terror. When a horrifying event shatters those core assumptions, the psychological equilibrium is destroyed. The mind can no longer predict safety.
Our sources also make a fascinating distinction between the types of events that cause trauma. They contrast natural or technological disasters like an earthquake, a hurricane, or a bridge collapse with human-made disasters like terrorism, assaults, or interpersonal abuse. And the data shows that human-made disasters make post-traumatic stress disorder, or PTSD, significantly more likely to develop. Why is that? Why does a mugging traumatize someone more often than a tornado?
It comes down to the element of intent to harm.
Intent.
Yes. A hurricane is devastating. It can destroy your home and threaten your life, but it doesn't have malice. It's a blind force of nature. Your brain can process it as terrible luck or a geographic hazard, but when a human being intends to cause you harm, it represents a profound existential betrayal of the social contract.
But the betrayal cuts deeper.
It violates the basic trust required to live as a social animal in a community. If a person can look you in the eye and choose to hurt you, it makes the entire world suddenly unpredictable and infinitely dangerous. The psychological impact, the shattering of the worldview, is much more severe because the threat is other people.
And when that acute trauma solidifies into chronic PTSD, the DSM-5 categorizes the symptoms into 4 main clusters.
Right. Let's walk through those.
First, there's re-experiencing intrusive memories, terrifying flashbacks, night terrors. Second, avoidance, deliberately staying away from thoughts, feelings, or physical places associated with the event, like changing your commute so you don't drive past the scene of an accident.
Exactly.
Third, negative alterations in cognition and mood, feeling entirely isolated, unable to feel positive emotions, feeling an exaggerated sense of blame or guilt. And finally, altered arousal hypervigilance, insomnia, irritability, an exaggerated startle response where a dropped book makes you jump out of your skin.
Those are the clinical symptoms. But again, a list of symptoms doesn't explain the mechanism. To truly understand why a traumatized person jumps when a book drops, we must look at the neurobiology. How does the brain actually physically process a terrifying threat?
The sources explain this by looking at how the brain develops, which is a model called the triune brain. It develops sequentially from the bottom up, almost like building a house from the foundation to the roof.
That's a great way to visualize it.
At the base, you have the brainstem, often called the reptilian brain. This handles pure survival heart rate, breathing, body temperature. Above that is the midbrain, the limbic system, which is the mammalian brain that handles raw emotion, threat detection, and memory. And finally on top is the neocortex, the highly developed thinking, rational, language processing center.
Under normal circumstances, the neocortex is the CEO of the brain. It's in charge. It can assess a situation, apply logic, and regulate our emotions.
So it keeps us calm.
Right. If someone cuts you off in traffic, your limbic system might flare with anger, but your neocortex steps in and says, calm down, it's not worth causing a crash. But during a traumatic event, a massive neurobiological shift occurs. The neocortex literally goes offline.
Wait, what do you mean offline? It just shuts down?
Yes. The brain senses overwhelming, imminent danger. In a fraction of a second, it calculates that there is zero time for abstract thought, logic, or debate.
It bypasses the CEO.
Entirely. The limbic system, specifically the amygdala, which acts as the brain's ultimate smoke detector, takes over completely. It initiates a hostile takeover of the brain's resources.
Because thinking takes too long. If a tiger is jumping at you, you don't want to stand there philosophizing about the nature of the tiger. You just need to run.
Exactly. The amygdala instantly signals the sympathetic nervous system to dump adrenaline and prepare for fight or flight.
And what if they can't run?
If fighting or fleeing isn't physically possible, say in cases of childhood abuse or being pinned in a car wreck, the amygdala engages the parasympathetic nervous system to initiate a deep freeze response, shutting the body down to minimize pain. This all happens automatically, instinctively, entirely without the thinking brain's involvement.
And the chemical cascade that goes with this hostile takeover is intense. The sources detail the biological mechanism of the HPA axis, the hypothalamic pituitary adrenal axis.
Yeah.
During trauma and the chronic stress that follows, there's a massive dysregulation of cortisol, which is our primary stress hormone.
And this cortisol dysregulation has a brutal domino effect on the rest of the brain's chemistry.
Oh.
High chronic levels of cortisol activate a specific enzyme in the body called TDO.
And what does TDO do?
You can think of a traumatized brain like a city under siege. Cortisol is the air raid siren. To fund the military response, the city has to shut down the entertainment and happiness budget. The TDO enzyme is the mechanism for that. When TDO is activated by stress, it essentially eats up the amino acid tryptophan in the body.
Wait, tryptophan. And tryptophan is the vital precursor to serotonin, right? The neurotransmitter responsible for mood stabilization and happiness.
Exactly. So by depleting tryptophan to fuel the stress response, the trauma is literally physically starving the brain of serotonin.
Oh my God.
This leads to massive mood dysregulation, profound anxiety, and deep depression. The physical architecture of the brain's chemistry is altered by the traumatic event. The person cannot simply cheer up. because the biological building blocks for happiness have been consumed by the survival system.
That mechanism completely validates the physical exhaustion of PTSD. But here's the detail from the research, specifically from the work of Dr. Bessel van der Kolk, that I found most staggering.
The language center.
Yes. During trauma, while the limbic system is raging and cortisol is flooding the system, a very specific part of the neocortex called Broca's area shuts down entirely.
This is perhaps the most crucial finding in modern traumatology. Broca's area is the language and speech center of the brain. It is responsible for putting our thoughts, feelings, and memories into coherent words.
So if someone's Broca's area is literally turned off during a horrifying event, what happens to the memory of that event?
Because there are no words available to process it, the memory is not stored as a cohesive narrative. It cannot be filed away in explicit memory as a story with a beginning, a middle, and an end.
So where does it go?
Instead, it's stored in the implicit memory system. It's stored as raw, fragmented sensory data. The smell of alcohol, the visual flash of a fist, the physical sensation of cold ground, fragments of sound.
That sounds absolutely terrifying.
It is the tragedy of trauma. When a PTSD flashback occurs, the person doesn't feel like they are remembering something from the past. Because the memory was never encoded with language or timestamps, when the sensory fragment is triggered, the brain reacts as if the event is happening right now in the present moment.
They are reliving it.
Exactly. The traumatized individual experiences emotions as intense physical states rather than verbally encoded experiences.
Which brings up a massive, glaring question about how we treat this. If someone's Broca's area was offline during the event, and the memory exists as raw physical sensation without any words attached to it, how on earth can a counselor sit them down in a chair, look at them across a desk, and ask them to talk about their feelings in therapy?
Right.
I mean, if the brain doesn't have the words, doesn't traditional talk therapy become essentially useless?
It's an incredibly insightful question, and the hard truth of the clinical world is that traditional language-only talk therapy often is highly limited and sometimes even re-traumatizing for severe trauma.
Because you're forcing them to use a system that doesn't have the data.
Precisely because of this language barrier. If the trauma lives locked in the ancient midbrain, you cannot logic your way out of it using the neocortex. Asking a severely traumatized person to just talk it out is like trying to update the software on a computer when the motherboard is unplugged. The signals aren't connecting.
So how do we get in there? If the front door of language is locked, how do therapists help people heal?
Since the trauma is stored in the senses rather than words, therapists must use alternative methods to access the limbic system directly. This is especially true when working with traumatized children, whose neocortex and language skills are still biologically developing anyway.
And this brings us to expressive arts and play therapy. Now, I will admit, before I read these sources, I had a very dismissive view of play therapy.
Well, a lot of people do.
I thought it was just letting kids play with toys in a sandbox to make them feel comfortable before asking them questions. I didn't realize it is a deeply structured, scientifically backed neurobiological intervention.
It really is. Play is the universal primal language of childhood. It allows a child to express highly complex, conscious and unconscious thoughts, conflicts, and fears without relying on abstract language that they either do not possess or that has been entirely blocked by the trauma response.
The sources outline specific curative factors of play therapy, and they are fascinating. The first one is called abreaction. This is the process of reliving a traumatic experience to gain mastery over it.
It's the mind's attempt to mentally digest a horrific, overwhelming event. It is externalizing the implicit memory. The text gives a very poignant real-world example. After the September 11th terrorist attacks, clinicians in New York observed many young children repeatedly building tall towers out of wooden blocks and then crashing toy airplanes into them over and over again.
Now, to an outside observer, to a parent watching that looks horrifying. It looks like the child is obsessed with the trauma or that they're traumatizing themselves further. A parent's instinct would be to take the blocks away and say, "Don't play like that."
But clinically, stopping that play would be a mistake. That repetitive play is the most potent way a child can affect internal change. Think about the reality of the trauma. The child was entirely helpless, witnessing terrifying adult chaos.
Right.
Through the play reenactment, the child is taking that helplessness and moving into an active, powerful role. They control the blocks. They control the plane. They decide when it crashes and how it is rebuilt. They are gaining a neurological sense of power and mastery over a memory that previously made them powerless.
That makes so much sense. Another curative factor the text highlights is stress inoculation. This is for future fears. If a child has severe anticipatory anxiety about something, say a terrifying invasive medical procedure they have to undergo, they can play it out in advance with miniature toys. They
Exactly.
get to act as the doctor giving an injection to a doll. It takes the terrifying unknown and makes it familiar and manageable.
And then there's the principle of counterconditioning. This is a fundamental psychological principle that dictates two mutually exclusive internal states cannot exist in the body at the exact same time.
Okay, meaning what?
You cannot be simultaneously deeply relaxed and highly anxious. You cannot be in a state of profound, joyous playfulness and clinical panic.
So how does the therapist use that?
By engaging a child in a safe, incredibly fun, playful environment while slowly introducing a mild trigger. For instance, playing an uproarious game of hide-and-seek in a slightly darkened room to help a child overcome a severe trauma-induced fear of the dark.
Oh, that's clever.
The therapist is deliberately pairing a positive physiological affect, laughter, safety, connection with the anxiety trigger. Over time, the positive affect overwrites the negative one, eventually extinguishing the fear response. It is a literal physiological retraining of the nervous system.
The sources also highlight some specific clinical tools used in expressive therapy to help clients process meaning. One that really stood out is the barrel of monkeys analogy.
Yes. This is often used with older children or adults to help trauma survivors chain together answers to the most agonizing, persistent question they face, which is, why did this happen to me?
Right. When someone experiences interpersonal trauma, their brain desperately tries to make sense of it, often by blaming themselves, because self-blame provides an illusion of control.
Yes, exactly.
The therapist has the client write down all the reasons they think the horrific thing happened. They might write, I was bad, I deserved it, I didn't fight back hard enough, or the world is fundamentally evil. They write these on little cutout paper monkeys, and they hook them together, physically linking them, just like the childhood game.
Why do you think physicalizing those thoughts is so effective?
Because it externalizes the trauma. It gets those toxic thoughts out of the murky implicit memory and into the physical space on a table where they can be looked at objectively, examined, and eventually challenged by the therapist.
Exactly. Because a massive part of trauma recovery is a fundamental linguistic and identity shift. The therapist must help the patient move their core identity from being a victim to being a survivor.
And the text defines those terms very carefully without any judgment attached. A victim is a noun describing the absolute impact of the event. It acknowledges the harm done, which is an essential first step.
Right. You cannot heal what you refuse to name.
You have to name the harm, but a survivor is someone who has come through the fire. Adopting the identity of a survivor means claiming your internal resources, your incredible resilience, and the immense strength it took to cope and stay alive.
Exactly.
Wait. If the amygdala is basically a hypervigilant guard standing on the wall of a fortified city, shooting arrows at any perceived threat, is play therapy basically a Trojan horse?
That is a remarkably accurate analogy. Explain how you see it.
Well, the traumatized brain is the fortified city. The amygdala is the guard seeing threats everywhere, keeping the gates bolted shut to protect the person. If a well-meaning therapist marches up to the gate and says, "Hi, I'm here to talk about your horrific trauma," the guard immediately shoots arrows at them, which looks like avoidance, dissociation, anger, or running away.
Yes, all those defense mechanisms.
But play therapy is the Trojan horse. It looks like a toy. It looks like harmless fun. The guard lets it inside the gates. It sneaks right past the brain's defense mechanisms, right past the amygdala, and delivers the powerful healing intervention directly into the limbic system where the trauma actually lives.
It is brilliant. By using symbols, toys, miniatures, and art, the therapist provides vital emotional distance. The child isn't directly talking about their agonizing abuse. They are talking about what happened to the bear in the dollhouse.
It's safer that way.
This safe distance lowers the amygdala's defenses, allowing the brain to finally process the raw sensory memories. It takes those fragments and slowly moves them from the timeless implicit memory system into the organized explicit memory system.
The brain can finally file the trauma away.
Yes, it encodes it as a story with a beginning, a middle, and an end. An event that belongs firmly in the past, rather than an ongoing imminent threat in the present.
Which transitions us beautifully from the mechanics of the brain to the actual frameworks therapists use to guide this healing. Because whether a counselor is dealing with the reward center hijacking of complicated grief or the limbic system lockdown of PTSD, they need structured frameworks to guide patients back to functioning.
And one of the most prominent, enduring frameworks for grief recovery is J. William Worden's 4 tasks of mourning. Now, remember earlier we established that mourning is an active, dynamic process, not a passive state of just waiting for time to heal you.
Right.
Worden deliberately uses the word tasks because it gives the griever agency. It gives them something to actively engage with.
Let's walk through these tasks. Task 1 is to accept the reality of the loss. This involves fighting that initial powerful numbness and the pervasive feeling that, this isn't really happening. They're going to walk through the door any minute.
Task 2 is to process the pain of grief. This is perhaps the hardest one. It means actively allowing yourself to feel the crushing sadness, the anger, the profound guilt, rather than avoiding it through overworking or self-medicating with alcohol or drugs to numb the nervous system.
Task 3 is a massive undertaking, adjust to a world without the deceased, and the sources break this down into 3 distinct areas of adjustment. First, external adjustments, figuring out how to pay the bills, mow the lawn, or cook dinner if the deceased used to handle those roles.
The daily living stuff.
Exactly. Second, internal adjustments, answering the identity question, who am I now that I'm no longer a wife or no longer a son? And finally, spiritual adjustments, grappling with how this senseless loss affects your core belief system or religious faith.
And finally, task 4 is to find a way to maintain an enduring bond with the deceased while embarking on a new life.
This is where the clinical literature discusses cognitive behavioral therapy, or CBT, which the sources cite as the primary, most effective treatment for complicated grief. CBT focuses heavily on modifying maladaptive narratives and behaviors.
Yes. If we connect this to the bigger picture, for example, if a patient is stuck in task 2, completely avoiding the pain of grief, CBT might involve deliberate, gradual exposure therapy.
Like confronting the things they're avoiding.
Exactly. The therapist might gently guide the patient to re-expose themselves to avoided memories or walk with them to a location they've been terrified to visit since the death. If they are stuck in task 3 with maladaptive, catastrophic beliefs like, my life is entirely meaningless now and I will never experience joy again, CBT works to logically challenge and restructure those toxic cognitions.
The text also heavily emphasizes narrative therapy and the concept of meaning-making. There's a concept from a researcher named Addig, mentioned in the sources, called relearning the world. I find that phrase so incredibly evocative.
It perfectly captures the massive cognitive load of grief and trauma recovery. When a catastrophic loss or trauma occurs, it shatters a person's previous internal template of reality. They literally have to relearn how to interact with their environment.
From the ground up.
They have to relearn how to trust other humans, how to find purpose in a day, how to inhabit their own body safely.
The goal isn't to go back to the old world because that world is gone.
Exactly. And this points to the fundamental goal of all these therapeutic frameworks. The goal is not to forget the trauma, and it is certainly not to forget the deceased.
Which people often think it is.
That is a huge societal misconception, that healing means forgetting. The actual clinical goal is what the literature calls emotional relocation.
Emotional relocation. Finding a new psychological space for the loss.
Precisely. It is taking the memory of the deceased or the memory of the trauma out of the dead center of your daily functioning, where it blocks the sun and dictates every single reaction you have, and relocating it to a place of honor or a place of context in your memory. You maintain a lifelong bond, but you clear the psychological space necessary to reinvest your energy into living in the present.
I want to ask you a question directly on behalf of the listener, because everyone listening to this will, at some point, have a friend or a family member go through a profound loss or a trauma. If I'm trying to support a friend going through this, how do I avoid the trap of just offering simple solutions to complex grief? The text specifically warns against offering easy answers, but when someone is crying in front of you, the urge to say something to fix it is overwhelming.
It is entirely human to want to fix the pain of someone we love. It makes us deeply uncomfortable to witness suffering. But complex grief and trauma cannot be fixed with a platitude.
Right.
Saying things like, everything happens for a reason, or God needed another angel, or they are in a better place, often causes immense harm. Those phrases, while well-intentioned, effectively shut down the griever's ability to express their very real, very ugly anger or despair. It tells them their dark feelings are not welcome.
It's toxic positivity.
Yes. The most clinically effective support is simply holding space. Validating their excruciating pain without trying to rush them through it to make yourself feel better. Listening without judgment, without offering unsolicited advice, and above all, recognizing that their recovery will be on their own messy timeline, not yours.
Holding space sounds so simple, but energetically it is incredibly taxing. Which brings us to the final reality of this deep dive. We've talked a lot about the patient's brain, but the hidden, often ignored side of counseling is the profound toll this work takes on the professionals themselves, the therapists who sit in those rooms day after day holding that space.
Working with highly traumatized populations, especially vulnerable children, is an ethical and emotional minefield that tests the limits of human endurance.
To illustrate just how complex this is, the sources provide a very specific, incredibly intense scenario regarding a 14-year-old girl named Emily. I want to spend some time laying out the details of this case because it perfectly encapsulates the impossible choices counselors face.
Please do. It is a quintessential ethical dilemma.
Here is the setup. A rural counselor with only basic training is approached by a mother. The mother asks the counselor to see her 14-year-old daughter, Emily, who has suddenly started refusing to go to school and is acting out.
Okay, pretty standard so far.
But here's the catch. The parents are in the middle of a highly acrimonious, bitter divorce. The mother explicitly instructs the counselor to keep the therapy a secret from the father. She doesn't want him to know.
Oh boy.
Furthermore, the mother tells the counselor she wants them to write a clinical letter to her divorce lawyer stating that the father is an angry man and should be denied custody of Emily.
Before we even get to the teenager, that is already a deeply compromised clinical setup. The therapist is being actively pulled into a legal custody battle. Agreeing to write an evaluation on a father they have never even met is a massive conflict of interest and an ethical violation right out of the gate.
But it gets so much worse. The counselor takes the case. Once in the safety of the therapy room, Emily begins to trust the counselor. She reveals that she's been smoking marijuana heavily with an older teenage boyfriend to cope with the divorce. She begs the counselor, weeping, not to tell her furious mother, terrified of the punishment.
That's tough.
And then a week later, Emily arrives at the session in extreme psychological distress. She reveals to the counselor that she has just been statutorily raped by a 25-year-old neighbor.
This case study is a nightmare scenario for a clinician. It highlights the agonizing tension between three competing forces, the sacredness of clinical confidentiality, the psychological concept of the mature minor, and the rigid, unforgiving reality of mandatory reporting laws.
I look at this scenario and it feels like the therapist is trapped in a lose-lose situation. Think about it. How on earth do they balance honoring this teenager's trust, a traumatized teenager who finally desperately found a safe space to disclose a horrific assault, with the legal requirement to involve the police and her angry, warring parents?
It's incredibly complicated.
If the counselor reports it, Emily might feel utterly betrayed, her one safe haven destroyed, and she might never trust a mental health professional for the rest of her life. If they don't report it, the counselor is committing a crime and leaving a vulnerable child in proximity to a predator.
This raises an important question about the limits of confidentiality. It is the heaviest burden in the profession. In therapy, confidentiality is the bedrock of the alliance. Without it, therapy cannot exist. But it is not absolute.
So what do they do?
In almost every single jurisdiction, licensed health professionals are mandated reporters. The sexual assault of a 14-year-old by an adult must be reported to the authorities and Child Protective Services. There is zero legal or ethical gray area there. The safety of the child supersedes all other concerns.
But doesn't that just obliterate the therapeutic trust? Doesn't the counselor become just another adult who betrayed her?
Not necessarily, if the clinician is highly skilled and ethical. A competent therapist would have conducted a thorough pre-treatment meeting, explaining the strict limits of confidentiality before therapy ever began, so Emily knew the ground rules.
Setting expectations.
Exactly. When the horrifying disclosure happens, the therapist doesn't go behind her back. They work with her. They validate her terror, but they explain clearly that they are legally and morally obligated to report it to keep her safe.
They don't just spring it on her.
Right. They offer her agency within the crisis, offering to make the phone call together, or offering to hold her hand when the parents are informed. The ethical requirement is to act in the best interests of the child. In this acute crisis, ensuring her physical safety from a rapist absolutely supersedes her desire for privacy.
Okay, but what about the marijuana use? Because that is illegal too. Does the counselor have to call the cops and the mother about the weed?
That is where the psychological concept of the mature minor makes things incredibly murky and reliant on clinical judgment. Depending on the state laws and the counselor's assessment of Emily's maturity and cognitive capacity, they might choose to keep the marijuana use confidential.
Really? They can just not tell the parents?
Yes, because the goal is to preserve the therapeutic alliance, using the therapy to help Emily uncover why she is self-medicating and guiding her to make safer choices. Immediate, punitive disclosure to a warring mother would likely destroy the therapy entirely, leaving Emily with no support system at all.
The weight of making those life-altering decisions day in and day out, absorbing the trauma of others, leads directly to the systemic physiological risks counselors face. The sources detail a condition called compassion fatigue.
Compassion fatigue is a very real biological and psychological phenomenon. It is essentially a toxic combination of professional burnout and secondary traumatic stress. It is the cumulative emotional and physical exhaustion that results from prolonged, unprotected exposure to empathy.
Explain the mechanism of that. How does empathy become dangerous?
Empathy requires a therapist to imaginatively step into the emotional shoes of the patient. When a therapist sits with grieving, abused, and traumatized people for 8 hours a day, intensely attuning to their pain, the therapist's own nervous system begins to mirror that distress.
Like secondhand smoke.
Exactly. Their own HPA axis starts firing. Their own cortisol levels rise. Over years, their nervous system begins to wear down, leading to apathy, exhaustion, and physical illness.
And if left unchecked, this compassion fatigue can lead to an extreme and frankly chilling clinical phenomenon mentioned in the text called malignant alienation. I'd never heard this term before, but reading about it made my stomach drop.
It is one of the darkest realities of institutional mental health care. Malignant alienation occurs in hospital wards or clinics when a treatment repeatedly fails, or a patient chronically relapses, particularly highly complex, chronically suicidal patients who don't respond to standard care.
What happens to the staff?
The staff, who are already profoundly exhausted and depleted by compassion fatigue, begin to lose their capacity for sympathy. They defensively detach. They start viewing the patient's severe psychological distress, not as legitimate pain, but as provocative, unreasonable, attention-seeking, or manipulative behavior.
The caregivers, the doctors and nurses, actually turn against the patient.
Yes, they alienate the patient. They might become sarcastic, punitive, or ignore the patient's cries for help. And this malignant alienation profoundly increases the patient's risk of completing suicide because their very last, most critical support system, the medical professionals, has actively rejected and abandoned them. It is a tragic, lethal breakdown of the therapeutic environment.
It's horrifying, but hearing about the biological toll of empathy makes it understandable how good people can end up doing terrible things when their nervous systems are burned out. So how on earth do clinicians survive this career without doing harm?
Through rigorous, mandatory supervision, where they regularly discuss their caseloads and their own emotional reactions with senior peers. Through deep, continuous self-reflexivity, constantly monitoring their own biases, triggers, and physical exhaustion. And ultimately, by recognizing their own limitations, practicing aggressive self-care, and having the humility to know when they are too depleted to help, and referring a complex case to someone else.
Wow. We have covered a truly massive amount of ground today on this deep dive into the hardware of human suffering. We started by redefining the factual reality of normal grief, dismantling the myths of the 5 stages, and honoring the profound biological resilience of the human spirit.
You did.
We looked at those incredible fMRI scans showing how complicated grief literally hijacks the nucleus accumbens, making the yearning for the past act like a powerful neurochemical addiction.
And we explored the biological architecture of trauma, how a shattered worldview causes the amygdala to initiate a hostile takeover of the nervous system, silencing Broca's area, depleting serotonin, and trapping terrifying memories in fragments of raw sensation.
We saw how ingenious interventions like play therapy act as a Trojan horse to bypass that locked language barrier, using toys and symbols to heal the limbic system. We explored how frameworks like CBT and meaning-making help patients achieve emotional relocation, finding a new space for their pain so they can reinvest in life.
Yes.
And finally, we looked at the heavy, agonizing ethical burden carried by the professionals who sacrifice their own nervous systems to guide this healing.
It is a profound testament to the complexity of the human mind, both in its immense vulnerability to shattering and its incredible biological capacity to repair and heal. And I want to leave you, the listener, with a final provocative thought based on the frontiers of our source text.
Oh, I like a final thought.
It concerns the science of epigenetics and the intergenerational legacy of trauma.
Okay, lay it on us.
We now know from genetic research that early life adversity and chronic severe stress can cause lasting epigenetic changes to our glucocorticoid receptors. Essentially, trauma alters the way our DNA expresses itself, changing how our biology handles stress. And we know that this altered, hyperreactive stress blueprint can actually be passed down biologically to our children and grandchildren.
So trauma is inherited in our genes.
Yes. But here's the profound question. If unhealed trauma can alter our DNA expression for the worse, does healing our own trauma through intensive therapy actually reverse those epigenetic markers?
Wait, really?
Does achieving emotional relocation and calming the amygdala actually change the biological stress blueprint we pass down to the next generation?
Weird.
Can the hard work we do in a therapy room literally rewrite the genetic legacy of our descendants?
That is an absolutely staggering thought. If we do the agonizing work to heal our own minds, do we biologically heal the children we haven't even had yet? That's something for you to mull over long after this audio stops. Thank you for joining us on this intense, emotionally heavy, but incredibly vital deep dive. Remember, the diagnostic landscape of the mind might be murky, and the X-ray machine for the human soul might be permanently broken, but knowledge is the very best tool we have for generating true empathy. Until next time.